Oh, look at that.
And Dorothy will go to broadcast then?
We're good.
Thank you. Good morning, everyone. As you're signing in, we will be beginning in just about 1 minute, allowing folks the opportunity to sign in. Thank you. Well, good morning and welcome to our October educational call of the Ohio Hospital Association's statewide sepsis initiative. I am James Giuliano and I serve as Vice President of Quality Programs at the Ohio Hospital Association. It's my pleasure today to talk about our program, which will focus upon a highly effective hospital-wide team-based model for conducting sepsis case reviews. Joining us on our call today are members of the Ohio Hospital Association HIN, the OHA Statewide Sepsis Initiative, the Post-Acute Care Community, members of the Ohio Department of Health, and members of the Health Services Advisory Group. So welcome to all who are joining us today. Before we begin today's session, there's just a few details that we would like to address. The first one is that, as you know, a vital component of our initiative involves the collection of data. So please let me take a moment to remind our participating hospitals to please submit your monthly numerator and denominator data regarding compliance to the elements of the 3-hour bundle. Secondly, please know that you will be given an opportunity to type in questions through the chat box feature throughout the presentation. You do not need to wait until the end of the presentation. Simply enter them in through the chat box. Questions will then be addressed at the end of the presentation. This presentation is being recorded and will be posted on our sepsis webpage, which can be visited at ohiohospitals.org/sepsis and by clicking on the education link. There you will find all of our previously recorded sessions that do not contain member data. Again, that is ohiohospitals, plural.org/sepsis. This program has been approved for 1.0 contact hours of continuing nursing education. The OHA Quality Department will be processing attendance and evaluation forms for these web-based programs electronically. There is a link that you will be provided with to the evaluation tool. So you'll need to log on to that link, complete the evaluation, and by doing so, you will be requesting the certificate. The link is on the screen. It's through SurveyMonkey, so you can access that. You will have 2 weeks to complete this process from the end of our date today, so 2 weeks from today. If you have any questions whatsoever about this, you're welcome to contact Dorothy Aldridge. That's dorothy.aldridge@ohiohospitals.org, and her address is also on the screen. Please know that we are no longer using the fax submission option for the evaluation processing. Now, we always begin our calls by revisiting the goal of our statewide initiative, that being to achieve the OHA's board-directed goal of a 30% reduction in sepsis mortality statewide by the fourth quarter of 2018. And lastly, we encourage you to visit the OHA Sepsis website, which is a repository of resources and education. For example, the recording from our recently held September 28th Community Awareness event is there. And this event featured an Ohio sepsis survivor, his wife, and his care team from Fairfield Medical Center. I encourage you to take a moment to visit that. Now, our topic for today's call is conducting sepsis case reviews. It is my pleasure to welcome 3 hospital leaders from the Cleveland Clinic. Joining us today from the Cleveland Clinic to share their case review process are Caroline Armstrong, Dr. Anita Reddy, and Rebecca Rosario. Caroline Armstrong is Quality Director of the Respiratory Institute and ICU Operations at Cleveland Clinic. Dr. Reddy is Quality Officer of the Medical Intensive Care Unit and staff member of the Respiratory Institute. She is Associate Medical Director of ICU Operations on the main campus. Dr. Reddy also serves as co-chair of the Enterprise Sepsis Steering Committee. Dr. Reddy also is an assistant professor of medicine in the Department of Pulmonary, Allergy, and Critical Care Medicine at Case Western Reserve University. Rebecca Rosario is the Data Registry Manager for Core Measures at the Cleveland Clinic. At this time, I will turn the presentation over to our Cleveland Clinic team. Welcome.
Hi. Hi, this is Caroline Armstrong. Thank you for the opportunity for us to present today. Hi, about the Cleveland Clinic, just a little bit about us. We are comprised of 4,900 caregivers. We see a total of 6.6 million visits, with 164,000 of those being hospital admissions. We have 3,400 physicians and scientists and 1,888 residents and fellows. We comprise in Northeast Ohio of 10 regional hospitals along with our main campus. And Cleveland Clinic has locations in Toronto, of course, Northeast Ohio, Las Vegas, Nevada, Weston and West Palm Beach, along with Abu Dhabi. The Cleveland Clinic way, our mission is to provide better care of the sick, investigate into their problems, and further educate those who serve. Our strategy is with patients first to transform to value and use as basis for system growth. Our goals are patients first, caregivers, affordability, growth, and impact. And clinical enterprise priorities are engagement, high reliability, access to care, the use of care paths, virtual health or telemedicine, top of licensure for caregivers, and documentation, population health, and system development. Our behaviors include leading through change, demonstrate character and integrity, develop myself and others, and foster teamwork. We have an enterprise sepsis steering committee. It was formed in 2015. The primary goal is to decrease sepsis-related mortality. Our measurement for 2017 was around the non-present on admission mortality. In 2018, we will be looking at all mortality. Our secondary goal is to increase step 1 measure compliance. We have a core team that meets weekly. Then we have an enterprise quarterly meeting. We have measure development, data sharing, issues log, and local field case reviews. I'm going to turn this over to Rebecca.
Hi there, this is Rebecca Rosario, and thank you for the opportunity to share with you, learn from you and learn with you. I'm going to go over the failed case review process that we use. So just to tell you a little bit about the department that I manage, Quality Data Registries, we abstract all the core measures for 10 of the Cleveland Clinic hospitals, and we abstract the sepsis core measure for all 11 hospitals. We have a total team of 15 core staff and 4 per diems. With the sepsis group that reviews these cases, they do have a couple other core measures that they're responsible for, but it's a team of 5, and they review all of the cases, which are about 500 to 525 each quarter. We also do 100% inter-rater reliability testing for all of our Step 1 cases that are in our sample. And then all failed cases go through a 3rd review by myself or by one of the QDR coordinators. What we have noticed is that we do have, after we implemented such a detailed inter-rater reliability process, that we did see some decline in our overall sepsis scores, compliance with the SEP measure, but we really wanted to make sure that we had clean data that was abstracted correctly and consistently across the enterprise. Part of our role is also to have frequent communication with QualityNet. We do send them complex cases to have a discussion. A lot of times the first response involves further clarification just to make sure that we are getting a response that kind of matches previous responses and is in alignment with the specifications manual. In addition, we try to share feedback that we get from our providers to make sure that the responses are not missing alignment with their clinical practice. Another area that we work on is we did build additional questions into our focus study to assist the care review process. Certainly we answer all the CMS questions, but we added additional fields into our focus study that looks at what department admitted them, the time that they left the ED, if the care path was used for that patient, and then for each specific OFI, we have a drop-down box of different reasons that a case might fail to help the reviewers have a better idea of where the opportunities were and to save them time when they're reviewing the cases. In addition, we try to provide very detailed notes in the focus study so that they have a clear understanding of the presentation, what pulled the patient into the measure, and kind of what happened with each case. Okay. Looking at our failed case process, this is just a quick flow diagram of the process that we use to get the cases prepared for the failed case review committee. We do concurrent IRR along with the abstraction. Essentially, there's 2 separate focus studies completed for each case to prevent any bias or influence on the second abstract to make sure that we have a true distinct IRR focus study. We run a report and reconcile any mismatches. And then, as I mentioned before, all failed cases are reviewed a 3rd time just to make sure the data is accurate and there was nothing that was missed in the first review process. The hospitals are notified of all their opportunities via email. We also have a failed case notification in MIDAS, which is the vendor that we use. And then we also have created a sepsis failed case spreadsheet that kind of pulls all of the documents, all of the answers to the different questions into a spreadsheet so that they can send that out to their committee to review prior to the meeting. The hospital coordinators then follow up on any process issues that are identified when the committee meets. And essentially the core focus of the committee is to look at, was it a true process issue? Was there an opportunity for improvement of care? Or we do on occasion have cases that it's a core measure issue. So then we use those cases as examples to share with the measured stewards and further clarify with QualityNet so that we can hopefully have an impact and improve the measure. Our teams are multidisciplinary and they occur at all 10 hospitals. The hospitals meet once a month to review all the failed cases. So we have physicians present. We consistently have ED, ICU, and hospitalists for the hospitals that use that service. Pharmacy is present to provide expert advice for antibiotic selection and any medication process issues such as timing of delivery of antibiotics. We also look at the elements that we passed in the measure, not necessarily just what we failed. For example, we may have met the 3-hour criteria for antibiotic administration, but looking at the timing that the order was written, the order was verified by pharmacy and available to the nurse. We look at the timing of that because certainly our goal is not to be at 3 hours. We want the antibiotics given as quickly as they can be given. Lab is present. They're very good at looking at the detailed and having a report out for any opportunities related to lab collected specimens. And nursing, management, and also advanced practice nurses attend. That gives us an opportunity for the nurse manager to interview the nurse prior to meeting and share with the committee the findings after that interview. The advanced practice nurses do a very good job in helping us with pulling together education and project work of our committee. For quality, they're present for all the regional hospital meetings, and they're a great asset for looking for trending, and also to follow up if there is more than just a core measure issue, and it could be a potential quality of care issue that might need further review. And then quality data registrations president is the content expert of the core measure. We invite additional physicians, nursing, or other departments as needed, depending on where the opportunity for improvement was identified. Okay, so the committee members review the case prior to the meeting. It's very helpful when people come that they have a good understanding of what happened with the patient, what's the patient history, so that we can move forward with just kind of getting into the case and looking at the care provided. The meeting leader shares the history, the events of the hospitalization. They'll look at the severe sepsis presentation time, the opportunities, and any other relevant information. For us, I think the collaboration is so key to make sure that we have effective teams. Some principles that we find in our most effective teams is looking at having open dialogue and everyone's input being valued. We don't want anybody at the table to feel like they can't speak up, and we're open to whatever discussion or questions that they bring forward. We also have team members that look for ownership and opportunities to improve the care. So we want to avoid the not me attitude and look at it could be an opportunity that is also an opportunity that a physician and nursing, there could be multiple players involved that could have made the care better for that patient. So we want everybody to look for their opportunity, and our teams that exhibit that behavior team definitely have the most success. Also shared responsibility during transitions of care. It's a high risk time for the patient. Communication is key. So during those transitions of care, we want to look at what could have been done during the handoff, done better for the handoff from emergency to ICU or ED to the floor, so that we can avoid any delays or miscommunications. Another characteristic of our more effective teams is to look at consistent messaging to the teams that they represent, and also understanding that the measure is not perfect and focusing on the clinically relevant opportunities. When we look at a case and it's determined that it's truly a core measure issue and we're very comfortable with the care that was provided, we do not attribute an opportunity for improvement to any one of those cases. So results of our field case review include looking at tracking the area, the department that was involved. We collect the location, the type of unit, if it's emergency, tele, or critical care, the provider, and also the institute of the provider that was associated with the OFI. That's helpful for us to filter the data and be able to kind of pinpoint areas that require additional education. Also, we look at tracking the reason for the OFI, looking at not just that we had a failed repeat lactate or a failed fluid, but looking at the details of it. Was it an issue with it not being ordered, an order not being initiated, or order being canceled? Just to help us get a better understanding on where we need to impact our education. We try to identify process issues and look for feedback and look to educate the bedside caregivers. So additional field case review results is, again, focusing on process improvement. Some projects that have come out of this work are antibiotic cards, also tables for medication rooms to look at antibiotic compatibility for concurrent antibiotic administration, updates to the order set. We sent out sepsis posters. We have pocket cards as references for the LIP, and then also the nursing staff, and then also an educational module for the nurses and providers. So some challenges that we face is looking at, there's frequent updates to the measure. I think the measure in itself is challenging, so that creates issues, I think, with the field case review and just making sure that we're current, that our abstraction matches the current rules, and that everybody's aware of the current rules. There's varying levels of confidence in the measure. Also, inability to clearly identify a true time zero while caring for the patient. So part of our review is looking at this is when the patient fell into the measure, but is that close to the time that the provider would have been thinking the patient was septic, or was there something sooner that they should have caught or identified that really the care should have been provided sooner than the time that they met the core measure criteria? There's cultural differences within our enterprise hospitals. We have hospitals that see their volume is 10 sepsis patients a month, all the way to main campus that is over 250 patients a month. So with that, community versus mental health hospitals are within our facility. And then also a main campus, which is the hub of our enterprise. Another challenge is education across the health system. There's a lot of providers and a lot of nurses and a lot of people that we're trying to reach and make sure that we're all understanding things the same way. And then also documentation. There's always opportunities for more detailed documentation, which then can impact the coding in which patients are pulled into the measure.
So I think the next topic we wanted to discuss was our collaboration with the measure stewards. We started this fairly early on when the measure came out 2 years ago. We started off with a couple of different phone conferences with Dr. Lamena regarding the SEP measure and opportunities for improvement. So we had read the measure, we were in the midst of following the bundle compliance and analyzing our performance, and we found some challenges clinically on how to operationalize things and how the measure is written and how that reflects care at the bedside. So talking through some of these differences with them was very helpful in terms of how we approached our practice. We also had several opportunities to have discussions with the stewards at national meetings, as well as other individuals who were going through the same struggles as we did, and listening to each other's feedback. And that was very helpful also to the way we changed our processes. And as Rebecca mentioned, we've had continued email communication regarding specific clinical scenarios and points of abstraction that we needed clarification on. So they would be certain situations where the measure specifically asked for abstraction in a particular way. We would submit the question to QualityNet and maybe get an answer that we weren't completely happy with. And so we would escalate that to the measure stewards, and they would be very responsive to us and let us know that they agreed with our concern and that this is something they hope to address with future iterations of the measure. And I think one of those examples that we probably would want to highlight is related to renal failure. So I think if you have an abnormal creatinine in an end-stage renal patient who's on dialysis, you have to associate in the documentation that an elevated creatinine is due to the patient having end-stage renal disease or being on dialysis. Otherwise, it could potentially be abstracted as an acute renal failure patient. So, and then the same with patients on anticoagulation. If there's an abnormal INR, making sure that that was associated in the documentation with anticoagulation. And I think future measure changes starting in January will allow a little bit more freedom in that documentation. So things that we may think are clinically obvious as we're documenting in the chart and taking care of patients don't always fall in line with how the measure is written and how abstraction needs to occur. So I kind of went through this already, sorry. So documentation of end-stage renal disease, and then documentation of chronic kidney disease. And then the classic example of anticoagulation and elevated coagulation parameters. The other thing that we've struggled with is fluids given outside of a specific inpatient area. So whether fluids were given by EMS during the patient's transport, even from an outpatient area to an inpatient area, and there's clear documentation that the fluids were given. We couldn't count that unless there was a clear order we could find. Or fluids given in the OR. So in our ORs, they use a separate documentation system outside of our EMR. And a lot of those fluids are given by an anesthesiologist or an LIP. And so there's no orders to track down to be able to include the fluids for abstraction. And so we gave that feedback as well. And looks like those changes will also be implemented starting in January. So I think the last topic we wanted to share was our analysis of our results. As Rebecca mentioned, we keep track of our failed cases, where the opportunities are, if it's an opportunity with care or an opportunity with reconciling the measure with the bedside, with clinicians and how we practice. And so we have published a lot or shared a lot of our findings related to this analysis. So one is the inter-rater reliability process that Rebecca mentioned earlier. So this is something that at the time was unique and probably still is, where we have up to 3 rounds of reviews of failed cases to ensure that between abstractors we're getting reliable data. We had found prior to having a dedicated sepsis group abstracting our cases, there was a wide variety of abstraction processes from one hospital to another. So we felt this was really important to get a core group that specialized in sepsis because this measure is so complex. We've also shared some abstracts based on our results, none of which is surprising, I think. There's several studies out there that show that bundle compliance, increased bundle compliance results in a lower mortality. And, you know, that's the spirit of this measure. That's why we have this. But we've also been able to show more recently that bundle compliance also has a lower risk of readmission. And our group feels strongly that this is going to be something, a metric that will be held to fairly soon. Sorry, there's a little bit lag between the keyboard. So I think at this point, we'd like to open up for discussion and questions on how we review our failed cases and any other questions you have about our processes here at Cleveland Clinic.
Well, thank you, Caroline, Anita, and Rebecca for your very detailed overview of your, certainly your case review process, your slides, and for sharing the resources that you are employing and using right now. And, we'd like to invite participants to submit any questions that you may have through the chat box feature. We do have one in now that I'll go to, but in the meantime, I also wanted to call to your attention that in terms of tools, Dr. Reddy has mentioned that if there are tools that you are interested in, that they would be most willing to share those with OHA, and we can post those to our website. For example, sample letters to providers for follow-up on issues that were identified during case review. So like just a template of that would be helpful. So we will make those available through our website. Also on our website that we'd like to just share with you, you will find a resource that is a case review template. If you are not performing reviews now, or if you're considering performing reviews with a structure, what is on the screen right now is an example that the Northwest Ohio Regional Quality Collaborative developed about 1.5 years ago. And it is just a template for case reviews that can be tweaked. It can be modified to meet your needs. And we wanted to point it out to you. It is on our website. It's available to you. As we scroll down through this document, beyond the purpose statement and the introductory guidelines, what you will actually find will be a model agenda for a case review. Again, this could be modified to the needs of your organization. So if we scroll down a little further past the pre-procedural review, we'll get to an actual agenda that you see on the screen now. And the amount of time that you allot to it, or what the content of that agenda is, certainly could be revised according to the needs of the organization. This template was developed. As we scroll down, you'll notice that there are references that have been the basis of putting this template together in the Northwest region. So our references are listed here as well. And one other point of interest on this particular template is that that region felt it was necessary in their content to address end-of-life considerations as part of their case review as well. So that may or may not be appropriate for the case reviews that you're doing, but we just wanted to point this out as an available tool for you. So again, that's located on our website, and you're most welcome to access that and modify it. So our first question for the team is, how do you determine if you are comfortable with the care? Can you give an example of what you would call a core measure issue?
Absolutely. So I think early on, prior to a lot of the measure clarifications, we had a lot more of, say, a measure issue rather than a clinical care issue. So some of these scenarios include patients who might have a massive hemorrhage or go into atrial fibrillation with RVR, and during the course of abstraction, if a patient was coded as sepsis somewhere during their hospital stay, they get included into MIDAS and get abstracted. But what we were finding is that the first point in which a patient may qualify in terms of SIRS and organ failure may not actually be a septic episode. It may be an episode where the patient had significant bleeding or AFib with RVR, and sepsis was actually down the road during their hospital stay. So unfortunately, how the measure is written forces us to abstract that initial period of instability. Another example that we've seen, and the measure has clarifications coming in January to address this, is the fluid piece that we discussed just a little bit ago. So not being able to count fluids that are administered in the OR or fluids that were administered during the EMS ride when we know that fluids were given, but we don't have an order as per the measure specification.
So in that situation, you deemed that the care was appropriate, it was on target, it just collided with, if you will, with the lineup of the criteria of the measure. And so that would be an example of what the requester is asking here in terms of what you're determining to be comfortable with the care. Is that correct?
That's exactly correct. That we feel that all the elements were provided for optimal care for the patient, but it's just the way we're being asked to abstract cases doesn't fully acknowledge that that care was performed.
Thank you. Thank you. That's very helpful. And you know, you mentioned also, Dr. Reddy, that you and your team as well, I think Rebecca mentioned this as well, have on numerous occasions provided feedback and dialogue upward about the core measure. And, you know, that process is so very important. It's one that will help to shape future iterations of measures, we would believe, but that feedback is so very, very important. So thank you for sharing that. But my question would be, could you share any type of pearls as to how that should be done, you know, the correct manner in which it should be done, if there are key phrases or words that need to be escalated during that feedback? If someone has a question, as you mentioned, you know, working with the steward, how does that process work? Can you talk a little bit more about that?
Yes, I think we're really fortunate to have individuals here who have direct relationships with the measure steward, and so we're able to connect us and have open conversations with them. Generally, what we try to do is group themes together. So since we do have the advantage of having several hospitals going through the failed case review process, if we find that themes are showing up, we will try and group those concerns together prior to emailing or contacting the measure steward. It's kind of a stepwise process. One, go through maybe a quarter's worth of case reviews, gather themes, make sure that they've been submitted to QualityNet first, and that we've gotten responses back, and if there's any other clarifying pieces of information we need to give, make sure there's a little bit of back and forth before we collect those themes to pass on to the measure steward. What I generally do is give detail about the clinical scenario and what was done, and they generally provide feedback within 1 to 2 days, indicating that, yes, that sounds like appropriate clinical care. This is something that we will plan or already have planned to address with the next iteration of the measure. So that's been our general approach. I know that it may be more difficult for those centers that may not have that already existing relationship with the measure steward, but I wonder if, as a collaborative, if there's something that could be gathered amongst all the hospitals and try and push it forward, say, under OHA.
You know, that's certainly a really wonderful opportunity, and we will certainly look into exploring how we could bring concerns together. Thank you. Our next question is, maybe for Rebecca, are there specific tools that your abstractors use to accurately abstract consistently?
Overall, of course, we use the specifications manual, and then we have a library of questions that's organized by the time of the spec manual to look at the discharge date of the patient, and then it's organized by the different data elements. So they do probably have additional resources just that we've built over time. Honestly, with sepsis, we have close to 1,000 QNet questions that we've submitted since the measure was started. So we are fortunate in some regards that with reviewing 11 hospitals, there's probably not too many scenarios that we haven't encountered. So then I think with that library is very useful to the abstraction team. Certainly, then we do team huddles. If there's anything that doesn't seem clear to the abstractor, we would submit an additional question if needed, but we do try to pull the team together, and if there's anything that seems gray, then we have a huddle with all of the abstraction team to kind of go through, look through the responses we've received and see if we've already got the answer, if we need to submit something new, because the documentation has to be so detailed for this measure. Sometimes you can't apply a past question just because there could be 2 words that are different in the sentence in the provider's documentation, which could completely change the answer to another way.
Thank you, Rebecca. Our next question deals with culture, and it's how did you address resistance to provider follow-up that resulted from case reviews?
I think at the field case reviews, we're very fortunate that Dr. Rios-Salvos and Dr. Reddy are very good to provide research. So a lot of times I'm the person from the committee that's on the field case committee. And so when the providers have questions, I feel comfortable because we have a lot of research articles that I can share with them that'll kind of highlight the best practice. Certainly there are times that we'll just say, we need to take the core measure failure. The care was good, you were the one that was there. That's not often, but we just want them to be aware of the current research and keep that in mind when they're making their decisions. So if we receive pushback on something that we know is evidence-based, then I make sure that we forward them the literature so that they can review that.
Thank you. Our next question deals with education. You had mentioned this earlier. The question is, how much education is provided to clinicians annually? And then the second part of that question goes on to say, is additional education provided as a result of case reviews, or does it default to the annual education? And if so, is it individual or is it group related? That's kind of a loaded question, but could you kind of address that whole education flow?
Sure. I can't say that we perfected the education, to be honest with you. When the measure first came out, we were actually already in the process of completing a pilot related to sepsis as part of our care path projects here at the clinic. So we had already had a bit of a jump start. But as part of the measure coming out, we had a couple of online modules for nursing and LIPs to provide education on what's expected as part of sepsis care. Since that time, a lot of the education is at a local level, so each department or each unit in terms of onboarding and whatnot. We have clinical nurse specialists who are also engaged in terms of educating nursing. We are actually in the process of revamping our education modules currently because we're hoping that the changes coming through with the measure are slowing down and that we could put some hard and fast information into these slides without having to change them, say, every 6 months. So we're in the process of working that out. Also, more recently, as Rebecca mentioned, we've been doing the pocket cards, so a handy reference for folks at the bedside to know what needs to be done within the 3 and 6 hour bundles. Rebecca also made a very nice 1-page reference sheet for handout as well. outlining what's expected as part of the measure, and I know a lot of institutions have been using that. In terms of regular annual education, we don't have a process for that at this time, but I think this is something that we are trying to ask for. There are several modules, as every institution has to do on a yearly basis, maybe a collection of 10 to 15, depending on your job role. And our team would like to add sepsis to that, but right now we're relying on kind of an onboarding type of education.
Well, thank you.
Part of the failed case reviews, we circle back around with leaders in the area to help drive those points home to some more focused education related to failures.
Great. Okay, thank you for clarifying that as well. Our next question is a question regarding lactic acid values, lactates. And the question is one that is asking why lactic acid value is just above normal value 2. We notice the majority of patients have lactic acid results close to 2. And I'm not sure if the nature of this is, the question is in line with the way that the measure is written, but would anyone like to address that?
It sounds like it may be a concern with the measure, and I personally can't speak to why a value of greater than 2.0 was picked, but there is some literature looking at intermediate lactate values between 2 and 2.5, which does show poorer outcomes in patients. So maybe I can't remember the reference off the top of my head, but that might be the basis for why CMS picked a cutoff of 2. I know that a lot of laboratory reference ranges are a little bit higher, maybe 2.2 or 2.3. We've addressed that by specifically creating a sepsis lactate test within our laboratory system where the cutoff is greater than 2.0. So there's an increased awareness that that's the threshold. We encourage people to use that particular lab test when addressing patients with sepsis, and that way it will flag as abnormal when it's greater than 2.0 rather than 2.2 or 2.3, which is the normal range in some of the other standard lab tests, say like a lactate/lactic acid or a blood gas. Hopefully that answers
thank
the
you.
question.
Thank you. And we have another question that has come in. And we'll read the question, and it says, very nice. Can Becky please expand on response from physicians? Do you have many non-employed physicians in this process or employed physicians? Are sepsis nurses still having issues getting private physicians on board? Thank you.
We have a mix of employed and non-employed physicians across our different hospitals. I think that over time, just the presence and the support that they get from the Enterprise Sepsis Committee, in addition to myself attending every meeting, then also a few times a year, the entire main campus team also visits the failed case review meetings so that we can offer whatever support that we can to help them with that. I think it is probably, like most follow-up, it is individual specific, depending on the provider. I think overall that sepsis is being identified, and anybody that works in healthcare recognizes this is a hot topic that requires a lot of attention. So I find that people are getting more receptive over time.
Thank you, Rebecca. The next question is with regard to data, and the question is, how is data shared once it is analyzed, and how often?
We've created what we use is a scorecard for each facility to look at bundle compliance in each element. So their data is released to them at the end of every month that is abstracted. We have a maximum of an 8-week turnaround from the end of the month that we've reviewed. So that is shared with each quality director and the coordinator in the regional hospital that is the kind of contact person that manages the sepsis failed case reviews and then also the follow-up. So they receive their data as soon as their cases are reviewed. That data then, depending on the hospital, is presented at various hospital committees, just depending on what their local structure is, that regional hospital.
Excuse me. Additionally, the our quality leadership team gets a monthly update on what's happening with sepsis, including our mortality rate and our compliance with step 1. And anything else that's new that we are doing, whether it was the posters or the pocket cards.
Okay, thank you. Our next question is interesting. Do you consider EMS-generated sepsis alerts and EMS initiation of actions in your case reviews? And in parenthesis under initiation of actions is the use of capnography in the field.
Currently, we do not do any of those.
Okay. So, you know, that concludes the questions that I have, and there's some wonderful questions submitted. If you have questions that you would like to submit, please, just as a reminder, to use the chat box feature or the question and answer feature. But while we're doing that, a question came in about just clarifying where folks can find the case review template. And again, that is at ohiohospitals.org/sepsis. And there's a section there for resources and tools. It would be found there. It also can be found under the link for today's program as an additional handout. So if you're looking at the education tab, you click that on, you go to today's presentation, there'll be the slides from today, as well as additional handouts, and that will be there as well. And Dorothy has placed that on the screen for you to see so that you can kind of get a visual as to where that's located. And the sepsis case review template can be found there as well. And while we're on this particular page, Dorothy, if you wouldn't mind scrolling down, we also will show you where the other recordings are found as well, so that you can see that they're all available. For example, in September, we had the code sepsis and the resource nurse concept from St. Joseph in Orange, California. Their tools are there as well that they promised to share with us. So please use this website as a resource. And there seems to be another question that has come in, so we'll go to the question and answer box. And that question is, do you see determining time zero for sepsis is becoming less difficult?
I think it's really case specific, you know, and I do think a lot of times it is getting easier just with all the provider education that has gone out, and I feel like that there's more of an awareness and the documentation is much more clear over time. There are still some cases that it's very tricky to determine. I think, you know, of the whole measure, that's the hardest question, is figuring out time zero. Once you know that, the rest of it's very easy. So I think it just kind of depends on the case.
Thank you. We don't have any further questions coming in, but I would like to thank everyone for joining us today. And in the meantime, as a reminder, our next call will be held on Wednesday, November 15th at 11:30 a.m., where we will provide an overview of the aggregate data from our OHA statewide sepsis initiative, which will be inclusive of the second quarter of 2017, as well as plans for moving forward in our goal to reach a 30% reduction in sepsis mortality by the end of 2018. Now, this call in November will be open to OHA member hospitals only due to the fact that the presentation will include aggregate member data. So wanted you to be mindful of that. We will look forward to having you join us then. And if there are no other questions, then this does conclude today's call. But we would like to, before concluding, again, express our gratitude to Caroline, to Dr. Reddy, and to Rebecca from the Cleveland Clinic for their willingness to share their expertise, their process, their lessons learned. And as we mentioned, the tools that they will be submitting to us, we will also post on the website as well. So Caroline, Anita, Rebecca, thank you so much. This concludes today's call, and I wish that everyone has a great day today.